My name is Susan Hammer. I'm president of the City Club of Portland, and I want to welcome you here today. First, please turn off your cell phones, electronic devices, and other things that make noise. A few announcements before we begin our program. Next Friday, on June 16, we'll have a fascinating forum entitled Oregon Free Speech, Too Much of a Good Thing? It'll be a debate between Charlie Hinkle and Kelly Clark, attorneys in Portland, and it'll be moderated by Judge Ellen Rosenblum. As usual, there's a lot going on at City Club, and here is a brief preview. City Club is seeking volunteers for ballot measure studies. We will soon know what measures will be on the ballot in the fall, and City Club's research board is recruiting volunteers who are interested in serving on a handful of ballot measure study committees. The commitment lasts about 8 weeks, beginning in July, and the committee then will report back to the membership in September or October this fall. For more information about this, or to request an application, please see Wade Fickler, right over there, Director of Research for City Club. In June, the Citizens Read book discussion will be reading Portland authors David Oates' book, City Limits. And we'll be meeting with the author to discuss the book on Monday, June 26. This book follows the author's walk of the urban growth boundary around Portland. And then on June 24th, just before the book discussion, the City Club New Leaders Council will join the author for a short boundary walk and to talk about issues of land use and urban development. Details on these events and the New Leaders Forum field trip to the Bull Run watershed are available in your bulletin. Speaking of healthcare, as we are today, the New Leaders Forum and the Healthcare Issues Committee will be hosting opportunities to meet with local healthcare leaders and learn what you can do to participate in the reform of our healthcare system. This will be on the Healthcare Reform Meetup Sign-Up on Wednesday, June 28th at City Club Commons, 5:30 to 7:30 p.m. Finally, summertime brings the return of the citizens' salons, intimate dinner discussions in homes of our members with great guest provocateurs, all to raise money for the City Club of Portland. At least one of the salons is already sold out, and many others are going fast. So please pick up your brochure from the registration form and make your reservations soon. The details of all these events can be found in your bulletin and on the City Club website, www.pdxcityclub.org, along with membership information about our TV and radio broadcast schedule, and of course the Citizens Blog online forum. You can also listen to today's forum online or purchase audio CDs and videotapes. Now, I'm delighted to welcome two new members to City Club today. They are Muriel Lezak and Barry Mount. Could you please wave new members and everybody join me in welcoming them? I'd also like to provide a special welcome to a group who is visiting City Club today. It's the Oregon Performance Internship and Leaders of Color. Director George Beard and about 23 students are back in that part of the room. Could you all wave? Okay. This is a program associated with the Hatfield School of Government, giving young people from Portland and outside of Portland experiences and training in matters of public policy. We're delighted to have you here with us. We're fortunate to have great corporate citizens in Portland who serve as our sponsors. Our quarterly sponsors now are Stoll Reeves LLP and Kaiser Permanente. Could you please join me in thanking our sponsors? Our program today is entitled The 4 Most Broken Things in the U.S. Healthcare and How to Fix Them by someone who helped make the mess. We Americans are consistently listing healthcare as one of the top issues that we are most concerned about. Skyrocketing costs, shortages of professionals, an increasing number of uninsured citizens, a system that is rich in resources for some and inaccessible to others. And all that function and dysfunction constitutes a whopping 1/6 of our economy. Our guest speaker today is Dr. Donald Trunkey, professor of surgery at Oregon Health and Sciences University. Dr. Trunkey is an internationally renowned healthcare visionary. City Club discovered that Dr. Trunkey, who some have described as a genius, has spoken broadly in nearly every place in various parts of the world, the United States, except for Portland, reinforcing the old maxim that every expert is, by definition, from out of town. It took us a while, but today we're going to fix all that. Dr. Trunkey was one of the first surgeons to incorporate the concepts of preventable death methods and evidence-based and evidence-based practice in support of trauma systems. He is an advocate for improved trauma care, not only at OHSU, but throughout the United States. Hard as it may be to imagine that Dr. Trunkey has any spare time, he does, and he uses it on an interesting array of activities. He's an avid reader, mostly history. He makes wine with a few friends. He has a big vegetable garden and herb garden, and he prepares most of the meals at his home. I think he must never sleep. Please join me in welcoming Dr. Donald Trunkey.
Good afternoon. I want to thank the organization for inviting me to come here and address you. I'm going to be giving you a fair amount of facts. I'm going to share my biases and my prejudices, and I hope to convince you to become part of the solution in changing our current health care paradigm. The first thing I want to do is to read a couple of quotes. We live in a great country that has got the best healthcare system in the world, and we need to keep it that way. George Bush, June of 2003. We do have the best healthcare system in the world. Bill Clinton, February 2000. I would like to dispel both of those statements. You can measure health care by a couple of kind of neat, simple ways. You can look at the cost of health care and longevity in a country. I'll give you 4 countries. In the United States, we live 77 years at a cost of $4,800 per person. In Spain, they live 2 years longer than we do at a cost of $1,100 a year. In Canada, they live 2.5 years longer at a cost of $2,700, and in Japan, they live 4 years longer at a cost of $2,000. Infant mortality is another good measure. In the United States, there are 6.9 deaths per 1,000 live births. In Denmark, it is 5.3. In France, 4.6. Sweden, 3.4. And Japan, 3.2. In the World Health Organization global ranking of healthcare, the United States is number 37. That's between Costa Rica and Slovenia, both developing countries. What are the problems with our current healthcare system? You've already heard Susan outline a couple. Access. 44 million have no insurance whatsoever. Now, you have to be careful with that because 18% of them make over $60,000 and they choose to go bare. They're young and they think they are invincible. But another 105 million are underinsured. The costs are staggering, $1.7 trillion, 16% of our gross domestic product. Pharmaceutical costs, 1,250% increase in the last 25 years. That's 8 times more than defense and 9 times more than the VA services benefits. And we have out-of-control malpractice costs. We're the only Western country that has a contingency fee. We're the only country that I know of that has punitive damages that go to the plaintiff or the attorney instead of what they were meant for. Punitive damages were meant to fix the problem. I think that the U.S. healthcare system is the best mediocre healthcare in the world. I think access to our healthcare is a lottery. Why is it the people who live in the same neighborhood where Johns Hopkins are poor can get some of the best health care in the world, and yet poor people in other cities do not have that same access? What used to be a not-for-profit system has become a for-profit system. When I was growing up as a kid in Eastern Washington, the hospital names told you a lot. Sacred Heart, Deaconess, Mercy, Holy Family, and some communities, small communities in that wheat farming area, actually set up hospital districts to pay for their community hospital. The first HMO was just a little bit before World War II, when Henry J. Kaiser founded the Kaiser Health System to take care of the ship workers in the Oakland area. It's interesting that Kaiser Healthcare was shunned by the rest of organized medicine, both doctors and hospital administrators. And in fact, they couldn't join the medical societies until 1984. But it was good health care. There weren't very many frills, and you couldn't get everything, but then they usually contracted out for it. Things started to change during the Vietnam conflict when Alan Enthoven, an economist, worked for Robert McNamara. He was the one that came up with the body count in order to measure the success of the war. And of course, one of the generals said that that was the height of arrogance because it clearly didn't reflect what was going on and it was subject to scams. Then Enthoven went to work at Stanford, and this is when he introduced his consumer choice health plan. The American business community were tired of healthcare costs, and they wanted some alternative. And the percent of the gross domestic product at that time was about 10%, and so we've gone far beyond that. But Enthoven's idea was to have a competition between health insurers. And not too long after that, there were at least several small ones, but there were 2 large HMOs founded, U.S. Healthcare and Humana. Now, these weren't very popular with physicians because they had to negotiate their fees or income back to their practices. The CEOs of both of those institutions did very well, however, and they made it into the Forbes richest 400 people in the United States. But they didn't really succeed. Then when the Clintons were elected president in 1990, Bill charged Hillary with basically coming up with a national health care system. And that led to the Jackson Hole Conference in 1992. Now, she did not include the very people and organizations that were going to have to provide that care. Thus, it really didn't go anywhere as far as a national standpoint. But there was, right after that, a very dramatic increase in HMOs both governmental HMOs, not too many, and then for-profit HMOs. Let me give you some examples of the government HMOs. In 1994, the state of Tennessee introduced TennCare. This is a government-managed HMO. In 2004, it took up 1/3 of the state budget, covered 1.3 million in a state with 5.8 million, and according to the Wall Street Journal, it represented 10 years of mismanagement and lawsuits, and it's still plaguing the state coffers. Oregon, under the leadership of Dr. John Kitzhaber, set up a Medicaid plan that was truly unique because the public had input on what diseases would be ranked in treatment. And the public made some incredibly good decisions. They would give liver transplants if you had cryptogenic cirrhosis, but they would not give a liver transplant if it was due to alcohol. And so self-abusive disease were not included. It failed, and I think in no small part because when passed by the legislature, they eliminated the amount of dollars coming from small businesses. And so that left out about 16% of Oregonian citizens from health insurance. Massachusetts recently passed a law mandating everybody be covered by health insurance in 2007. Governor Romney also vetoed the input from small businesses. Now let's shift and go over to the for-profit HMOs. Oklahoma Medical Center. The University of Oklahoma Medical Center is run by HCA, the largest HMO in the United States. At the University of Oklahoma, a craniotomy for an uninsured patient costs $85,000. Now, this represents the retail price. If you had lots of money, you could go there and get your craniotomy for the same price. Blue Cross Blue Shield, however, only pays at that hospital $15,600. That's the discounted price that goes to commercial insurance. And an even slightly less fee is paid by Medicare, which is $13,900. Now, how can you explain this? Well, you can't. I mean, it's between $85,000 and these 15 and 13, you just can't explain it. A Seventh-day Adventist hospital in Orlando, Florida charges an uninsured patient $35,000 for an appendectomy. That's $7,000 more than I made the first year I was an assistant professor of surgery at the University of California, San Francisco. I could have paid everything with just one operation that year. That same procedure, appendectomy, for Blue Cross Blue Shield is $7,000, and for Medicare it's $6,200. But let's look at it from the standpoint of the patient. And this is at Presbyterian St. Luke's Medical Center in Denver. AS gives birth to a baby girl. It has defective bronchial tubes. Stays in the hospital for several weeks. The mother leaves, obviously, on the second day. The husband gets a bill after the baby is discharged for $213,802. That's 6 times the husband's salary, and his insurance does not cover the baby. He writes a letter saying that he can't pay it, and the hospital writes a letter back stating that they will adjust the bill. And they adjust it $85,000, and therefore the settlement amount is $128,281, and they say you have 30 days to pay. If you cannot pay, we will give you a credit card. And the $128,000 is put on the credit card. 17% interest, 40 years to pay, total amount paid $777,153, and the annual payments are $21,833, 2/3 of the husband's salary. Let's look at HCA's record. In 2000, it was almost 200 hospitals. They made $21.8 billion in revenue that year. Tom Frist owned 17 million shares. Presumably, his brother owns the same amount, although it's in trust. They defrauded Medicare, Medicaid, and TRICARE that year $63 million. They overcharged the uninsured $2.1 billion. They paid $840 million in criminal fines, civil restitution, and penalties. They paid $250 million to Medicare for overbilling. Overall, they paid $1.72 billion for fraudulent practices. Tenet is the second largest managed care organization. They bought NME in the 1990s. There also, the doctors and administrators have overbilled patients, insurers, and Medicare, charged for services and treatment never provided, signed false insurance claims, paid $40 million to doctors in kickbacks, and they've paid $379 billion in criminal fines, civil damages, and penalties. One of the most egregious examples of a Tenet hospital is in Redding, California, which is 238 beds. This is the Redding Medical Center. The hospital administrators hired Dr. Che Hyun Moon, a cardiologist, and Fidel Reale Vasquez, a cardiac surgeon. In 2002, they did over 1,000 cardiac procedures, billed and collected from Medicare $2.4 million. 167 patients died. $54 million fine was assessed by Medicare for unnecessary heart procedures. Patients with no symptoms at all were referred by Dr. Moon to Dr. Reale Vasquez, and they had their heart valves replaced. It's not confined just to hospitals. Physician practice management also comes under scrutiny. Medical Partners was a $6 billion a year profit organization in Southern California. In 1995, they said they were going to go public. FICOR, a second largest management group, proposed a merger with Med Partners. The books were examined, and they found out instead of $6 billion profit, they had lost $1.2 billion the previous year. And when this was revealed in public, they went into bankruptcy, and then another group, KPC Medical Management, owned by Dr. Kai P. Chaudhuri, bought it at a very cheap price and then proceeded to use a Ponzi scheme to sell the insurance to various people. And then he went bankrupt in 6 months, but he saved all of his own personal assets. Well, there are other problems as well, other scams, if you will. And I think one of the biggest ones are these so-called call centers. Well, how does a call center work? Well, let's take a 74-year-old female in San Leandro, California, who has Kaiser insurance, and she's had this for about 50 years. She wakes up one morning and she has some abdominal pain, but most of the pain is in her back. She calls her physician's office at 8:15, and this is immediately referred to a call center, where a non-health professional tells her that her physician is not in that day and that she will not be able to see him. Fortunately, about this time, her daughter comes over to her house, and they make a second call. They plead to the call center that her mother is really hurting and that she has to be seen. Again, she's put off. They make a third call, then a fourth call, and at 1:30 in the afternoon, they finally get a different person in the call center and plead with her that the mother is she's in tremendous pain. So they make an appointment in her doctor's office, who was not available before, at 4:30. They go over immediately, wait an hour, see the physician, and he immediately diagnoses that she has an abdominal aortic aneurysm, sends her to the hospital. She arrives in the emergency room. The aneurysm ruptures. They take her to surgery, emergency surgery, give her 20 units of blood. She never regained consciousness and died. These call centers are ubiquitous, and they are all over the United States, but many of them now are being managed out of India. Another example is the so-called radiology diagnostic facilities. These are called, euphemistically, Nighthawk, and they are located in Spain, Australia, and now there are even some centers in the United States that provide reading of digitized x-rays at night, and you can get a report back in 30 minutes. Now, there's some problems with this. As a surgeon, I take night call. I'm taking night call tonight, and if I get a CT scan of an abdomen or a chest or a head, I read it. But then the next day, the radiologists come in from my own institution, and they do a, quotes, overread, and they bill Medicare and Blue Cross Blue Shield for that overread, even though I've already made my diagnosis and my treatment decision based on what I read the night before. I think this is unethical. The other scams that occur are the CPT codes. Now, these are 9-digit numbers that we use for billing, and these are produced by a 16-member editorial panel through the AMA. There are 11 physicians on these panels, and they are paid royalties to be able to use these billing codes, and they are the only ones out there really available. Well, this leads to a reimbursement jungle because physicians can milk these CPT codes, and in fact, they can get professional help to do so. There is the American Academy of Professional Coders, and in Seattle, you can come up with 775 health insurance products based on these codes. And then the government hires these coders to make sure that they're getting their money's worth. 35,000 people do nothing but this. And then we have the same problem in length of stay. You know, you go to a hospital and then they tell you, well, you've used up your length of stay time. Well, these guidelines are developed or were developed for the government by Milliman, but now they're being used by hospitals as well. These administrative costs are absolutely staggering. In the United States, it's $1,059 per capita per year. That's what it's costing. It's about a fourth of our total health care costs. In Canada, the same administrative costs are $307 per capita. These administrative workers make up 27% of our health market, if you will. In Canada, it's 3.1%. The cost of the bureaucracy to do all of this is a staggering $375 billion a year. There are 1 million middlemen doing this kind of work in the United States. What about the doctors? How do they get involved in all of this? Well, let's take a very egregious example here, too. TAP is a pharmaceutical company made up of Abbott Laboratories and Takeda Laboratories in Japan. They have been selling two drugs primarily, Lupron, which is a drug that treats prostate cancer by doing a medical orchiectomy, and then an acid reflux drug, Prevacid. Now, there are 14,316 urologists who prescribed Lupron in 1997. 482 received 25% of the total Medicare payments for Lupron, 126 million. That year, Abbott made $2.5 billion off of Lupron. What was Takeda and Abbott doing? They were giving samples of blood, these Lupron to the urologists who would then sell it to the patients. They also gave them a 2% management fee for their office practice, $25,000 educational grants, and then paid for the trips to very nice resorts where they could get this education. They ended up paying approximately $290 million in criminal fraud charges, and $871 million to the government to settle the suits. These fraud cases are not limited to TAP. Pfizer paid $49 million, for Lipitor. GlaxoSmithKline, $88 million for Paxil, which is an antidepressant. Bayer, $275 million for Adalat, which is for high blood pressure. And AstraZeneca paid $555 million for Zoladex, what is their analog drug for Lupron. I just want to briefly look at some other problems. There's a physician at the Medical College of Wisconsin who in 2002 came out with an article that physician supply was going to reach a crisis by the year 2020. And at that time, he said that we were short of physicians about 100,000. Just 2 years ago, he came out with another paper, and he upped his numbers, saying that we were going to be short of 2,000 physicians, and 200,000 physicians, and that this was going to occur by 2010. So we're looking at a doctor shortage. People don't want to go into medicine anymore. I believe the physician shortage is here now. It's going to become worse, particularly when the baby boomers reach age 65. And again, most of this physician shortage is going to be in surgery, gastroenterology, and cardiology. Well, I'm just going to quickly look at some problems in trauma care because we're feeling it more acutely than anybody else right now, because there is a shortage right now. We have an additional 1 year of training that we must do after our surgical residency, and last year, only 40% of those positions were filled. And again, this is going to be exacerbated by 2010. The average age of the general surgeon in the United States is 59. So you can see where we're headed. We also have a problem because we can't get enough surgeons to do terrorism activities. We have disaster medical assistant teams, and on the West Coast, there's only 4 general surgeons willing to be members of those teams. We have a problem in the military, and I'll come back to that. Early in my career, I went on the American Board of Surgery, and at that time, we were training about 1,100 general surgeons a year in the United States, but only 925 would pass their board's examinations. And of those 900, 500 would go into surgical specialties, so we were only left with 400 general surgeons. It's now down to 300 general surgeons, and the applications to general surgery residency are going down every year. We make up for some of the differences by taking in foreign medical graduates. There's a major problem as it relates to gender. Graduating medical students now, rightly, are 50% women, but only 7% apply to surgery. That's about 500 applicants. Part of this disinterest is general surgery work hours. Part of it is lifestyle. Part of it is a desire to combine a professional career with being a traditional role as a mother. And it also reflects that the programs have not provided protected time so that they can do both. I was recently at the Medical College of Virginia, and they've turned the entire basement into a day and night care center for children. And this has been very innovative. The nurses, the physicians can then have their children cared for when they're on call. General surgery continues to become more fragmented and specialized. We now have foregut surgeons, we have liver surgeons, we have pancreatic surgeons, we have colorectal surgeons, we have breast surgeons. But the one thing they have in common is they don't want to take trauma call. Now, Tom Esposito, who's a friend of mine when he was at the University of Washington, did a study. He sent out a poll to every single surgeon in Washington State asking why they did not want to take trauma, try to treat trauma patients. The 4 top reasons: time commitment, compensation, dissimilar reimbursement from their elective practice, and a perceived increased medical legal risk. But there is no data to support that latter. My own take on this is that why surgeons don't want to do this: it's a nocturnal disease, it's disruptive to the OR schedule, disruptive to elective surgery, disruptive to clinic. It's a high user of ICU beds, and many of these patients are Blue Cross negative. So, the other problem that we're seeing countrywide and here in Oregon is that specialty surgeons are increasingly asking for exorbitant on-call pay. In the state of Florida, on the East Coast, a neurosurgeon asks, demands, and gets $7,000 a night to take call. And they only have to come in 1 out of every 10 nights. Orthopedic surgeons in Orlando are asking for $4,000 a night. I'm a little bit more sympathetic to the orthopedic surgeons because they have to come in 274 times in a year. A major problem that is going to affect trauma and medicine in general in 2010 is the 50% increase in the elderly population. Now, older people are more active. They go on recreation, they do a lot of things, and we're now seeing a bimodal curve in deaths for trauma. You see one in age 16 to 24, and then we see one now out in the elderly. If they have a severe injury, they are 3.5 times more likely to die, they spend more time in the intensive care unit, and only 25% go back to independent living status. That's because we have very poor rehabilitation for these patients. Only 1 in 8 patients with a traumatic brain injury gets into a rehab center. This is a general accounting office study. And again, they do not go back to independent living. Another problem that we have in trauma is 20% of the Department of Defense need for surgeon comes from active duty surgeons. We don't have people joining the military anymore. 80% comes from the reserve, and people are bailing out of this as rapidly as they can. Getting people to serve their country, to take care of injured soldiers is a big problem right now. Many trauma centers are closing or downgrading their level of care, and that includes Oregon. Salem downgraded from level 2 to level 3, Medford downgraded to level 3. The reason is they could not get the surgeons to provide that night call. Another problem that we see increasing now is dumping. In 2003, Congress passed the EMTALA law. That's the Emergency Medical Treatment and Labor Act. And this forbids us from saying no to some patients who are set up for transfer. In other words, I'll give you a classic example. I was on call about 3 months ago and got a call from an Eastern Oregon hospital, and the ER physician there said that he had 2 patients and the orthopedic surgeon couldn't come in to treat them. Would we take them? He said yes. So they put both patients on a fixed wing aircraft, and we saw them in the emergency room. One had a forearm fracture, left arm, and the other had a forearm fracture of the right arm. So at a cost of $12,000, these 2 patients were flown from Eastern Oregon because the orthopedic surgeon would not provide the care. This is common. It happens every night I'm on call. Well, let's look at some solutions. Firstly, I think we're going to have to have a paradigm shift. We're going to have to ask a very fundamental question. Is healthcare a public good? And then what is the role of a global economy? Now, the status quo is currently made up of employer, employee, patient, if you will, union negotiated contracts. And then we have government-provided health care. That includes military, VA, and public health. We have government-contracted health care, and that's Medicare, Medicaid, and TRICARE. And then we have the free enterprise pharmacy industry. Now, the disadvantages, I've already told you, I think the system is broken, access is a problem, double standard of care, malpractice, and then the absolute cost. In a public good model, which most economists believe that medicine belongs to, is much like the military, the fire, or the police. There's direct provision of care versus possibly contracted care. Access problems would be obviously eliminated. The disadvantage of the public good model is who would pay for it. The cost, many would argue, would increase. There's a loss of incentives, and there would be a maintenance of double standard because some people are going to just pay extra for the frills of some of the hospitals offer. And they always use the European and Canadian experience as bad examples of socialized medicine, if you will, if the public good model truly is socialized. Another model would be the public utility model. Now, this could be a regulated public utility model, and it could be done locally by the state or the feds. But if you don't do it federally, then I don't think it's going to work. Or it could be an unregulated public utility model where they set standards and but may not do all the costs. One of the most positive things about the public utility model is you would have, much like the public utility commissions, a health commission, and therefore public input. The biggest disadvantages of a public utility model would be gaming of the system. That happens all the time with utilities. Evidence is weak that it would work, and you still maintain the double standard. Bartlett and Steele, who are both journalists for the Philadelphia Inquirer, wrote a book called Critical Condition. And in there, they outline 12 things that would solve our healthcare problem. Number one, universal healthcare. I strongly support this. Single-payer system, I'm not so enthusiastic about because the Germans have a multiple payer system and there's competition that's brought into the play there. But I'm willing to listen to anything, and maybe we ought to look at other models in other countries. Bartlett and Steele recommend that this healthcare system be run by a quasi-government agency, and they just arbitrarily called it the U.S. Council on Healthcare, and they say it should be modeled after the Federal Reserve. I can't support that at all. I have a daughter-in-law who's a lawyer, and she's worked in many government agencies, including the post office and the Federal Reserve, and she tells me that the Federal Reserve is the worst example of bureaucracy in the United States, and so I'm a little bit skeptical of that one. Number four, a defined level of basic care. I strongly support that as well. Flexible copays. Yes, you have to have copays. You have to have some disincentive for people to abuse the system. Catastrophic care, absolutely. Freedom of choice, absolutely. Disease prevention, I couldn't support that stronger. 1/3 of Americans are obese, which leads to diabetes, hypertension, and you and I pay for this. Furthermore, we still have 500,000 people who die every year from cigarettes. So we've got to address this from a preventive standpoint. Curtail out-of-control drug costs, patient education, oversight of insurers, reverse overdiagnosis over treatment, and arbitrate malpractice. There is another set of solutions out there by the Progressive Policy Institute, and they only have 6. Universal health care equal to what our members of Congress have. Require shared responsibility for the cost of coverage. Pay doctors and hospitals according to their performance. Deploy information technology for better care and lower costs. Create health courts for reliable justice in malpractice cases, and then create a national cure center to speed medical breakthroughs. But then you'd have to include the executive branch because he's the guy that doesn't allow us to use stem cells. I am going to provoke you further here by introducing the world is flat model. We already outsource many of our pharmaceuticals. We import healthcare professionals every year. We've been doing nurses for years, and now we're starting to bring in physicians. In the Northeast right now, there are some training centers, surgical training centers, that have nothing but foreign medical graduates in them. And we could outsource surgical procedures, and I'll come to that in a second. And then we could continue and expand outsourcing of our diagnostic radiology and medical bureaucracy. We could do all of that tomorrow. And that, in my opinion, isn't going to change things one whit. It may make things worse. Let me show you the situation on outsourcing surgical procedures. You today can go to Singapore, Delhi, or Bangkok and get almost any elective surgical procedure you want, and at a tremendous cost saving. A heart bypass. In the United States, this is $54,700 up to $80,000. That's the insurer's cost. And then the retail cost that we talked about earlier is $122,000 to $176,000. In Delhi, you can get this for $10,000, and in Bangkok, $12,000. That includes your airplane ticket and your rehab. Hip replacement. In the United States, it's $18,200 to $26,000 for insurance companies, $43,000 to $63,000 for the retail. In Delhi, you can get this for $9,000, or in Bangkok, $12,000. Knee replacement, almost the same. And then spinal fusion. Now, you got to be cautious about spinal fusion. In the United States, 80% of those operations are not even indicated. Cost $26,300 up to $36,000, and then the retail price is $62,000 to $90,000. In Delhi, you can get this for $5,500, and in Bangkok, $7,000. Now, obviously, there's tremendous disadvantages to the global economy model. First off, we're never going to outsource trauma care. I mean, can you imagine a 24-hour pre-hospital plane ride? But look what it does to the developing countries. This is a brain drain. Bringing these people in from these other countries is a real problem. Secondly, professional competence. India has 205 medical schools, of which 20 are private. In one or two of those private schools, you can pay $10,000 and get your MD. Surgical training is awkward to say the least. Of the university-sponsored medical schools in India, 50 to 60% have very poor infrastructure, inadequate number of professors, and therefore we wonder about the product. And when we bring them to the United States and test them, then we give them one test, the United States Licensing Medical Exam, the USLME. There's no surgical test given. We don't test their psychomotor skills. We could do all of those things, but it's expensive. We would have to develop the test, maybe give them an American Board of Surgery exam. We could set up virtual simulators to test their psychomotor skill, but those cost about $2 million per machine, bare minimum. And quite frankly, the global economy model is a short-term solution in the first place. Well, I come to the end of this, and I'll just summarize. Our current healthcare system is broken. It is a high-cost, mediocre system. Access is a major problem. Pharmaceutical costs are out of control. Malpractice costs are egregious, and 40 to 50% goes to the attorneys. And the solutions are going to be very difficult. Thank you very much.
privilege of membership in City Club, to the extent we have time today, is to ask questions of our guest. Your question should be no more than 30 seconds, and it should end with a question mark. Our board host today will be asking the first question. He is Bill KRAMER. Bill is a consultant in healthcare management, policy and finance. He earned his MBA from Stanford, his bachelor's from Harvard. He is treasurer of City Club. Aren't we lucky to have him? Bill.
Thank you, Dr. Trunkey, for your informative and thought-provoking talk. Last week in the Oregonian, there was a feature article about the new hospital pavilion at OHSU. The authors used this as an example of what they described as a hospital arms race in the Portland metro area, leading to what they described as an oversupply of beds and high medical technology, which in turn leads to higher costs and a growing disparity in the services available to the haves and have-nots. To what extent is this a problem, and what should be done about it?
There's no question that this contributes to the high costs that we have in U.S. healthcare. To get into the real nitty-gritty here, though, I'm both a plus and a minus of this high-end hospital pavilion that we now have. First, you have to understand that OHSU has a disproportionate number of patients who are either flat-out indigent or are underinsured. It's 40% of our patients. And so we do rob from Peter to pay Paul. There's no question about it. The hospital is the engine that generates those dollars so that we can do indigent care. It's not right. It's not right at all, but that's the reality of 2006. The other thing is that the state does not pay the university enough to run the medical school. We're now charging in-state residents $30,000 a year tuition for their medical school. And some people figure it costs over $500,000 per student. And so the hospital, again, is underwriting medical education. The downside, though, is it is costly, and those frills that we see there are a little bit problematic to how we teach medicine, because we clearly have a double standard, if you will, in regards to the physical plants. On the downside, too, is how can you teach ethics to a medical student if you really don't practice it? And I think that this is all very transparent to the medical students. Good question.
Dr. Trunkey, Tom Cox, thanks for coming today. Are you a member of City Club, by the way?
No, I was early on, but I got tired in the health committee because they didn't want to move fast enough.
I was going to ask you, you say you're skeptical of single-payer systems, which I am as well. You didn't mention healthcare savings accounts or the Singapore approach or South Carolina's Medicaid reforms. Can you say anything about those?
The safety counts are interesting, but it's not going to solve the underinsured or the indigent. I mean, they're not going to have it. And quite frankly, that's not the way I would pay for the reform necessary. I personally, I'm probably going to get shouted down here, I personally favor a value-added tax. Everybody pays under a consumption tax. Business pays, small business pays, everybody pays, even the poor when they buy goods. VAT would be the easiest way to go for me.
Xander Patterson, City Club member. Significant health care reform doesn't seem to be anywhere near the agenda in Washington, and I think it may be wishful thinking to think Salem's really going to address the issue either. Is there anything we can do locally, city, county, or metro government to address some of the health care problems you cited?
Well, first off, just to agree with you, our executive branch is currently impotent, and it's not going to come from there. Congress is so polarized, so bipartisan. They're not only not addressing health care, they're not addressing a lot of other issues that should be addressed. And so I'm not optimistic. I personally believe it's going to have to be a grassroots revolt. And I think you're going to get a tremendous amount of help from the business community. Business community, I mean, look at it. You know, $1,400 of every General Motors product is healthcare. It's more than U.S. Steel. And the reason that manufacturers are going overseas to Asia now is that healthcare is one of the top 3 reasons. They can't pay for it anymore. So I think the business community would support us if we got a grassroots thing going among the public.
In the meantime, is there anything that can be done on the local level?
Well, start a grassroots campaign, yeah. I guess one more question.
Susan Pierce, member, former emergency department nurse turned hospice nurse. Just for what it's worth, the call pay that we get when we work night shift after having worked all day is $2.50 an hour, plus overtime when we actually see a patient. Compared to the 7,000 that you spoke of, the nursing is facing the same crisis in terms of. I want your comment on this, nurses, because you said very little about this. We're facing the same crisis in terms of diminishing members and the baby boomers becoming elderly. One reason is that many people who used to go into nursing are now going into medicine. Can you address that part of the equation? You can't.
Well, a big problem has been the dropping out of nursing schools. There are 40,000 people out there that want to become nurses, and there are no positions for them. That's one problem. And we continue to import nurses from Ireland, the Philippines, Europe, and quite frankly, that's not the solution either. And you're absolutely dead right. When the baby boomers hit, that's going to put a whole another level of demand for nurses.
Thank you very much, Dr. Trunkey, for an insider's view of the problem and some interesting possible solutions. If you'd like to continue this conversation, please visit the website at City Club and go to the Citizens blog. Thank you all very much for coming. We are adjourned.